problem. It's okay for me.
Okay, perfect. So, well, let's do this. Let's wait a little bit. I'll be back in 5 minutes, okay?
Okay.
Okay, let's start. Okay, let me share the slides and that's all I think. Please let me know when you can watch my screen. Hello, can you watch my
We can see it. Yes, teacher.
Yes,
Okay,
teacher.
perfect. Okay, let's start. As you know, today is our last class. Last theoretical class from Module 1, of course. And, well, according to that information, we are going to check just the general view about hospitals, primary care, medical education, and the overseas of a general practitioner, okay? Well, general information, not too deep, of course, because it's like an introduction for the next model, as I was telling you the previous week. And, well, in order we are checking the slides, I'm going to tell you which ones you might study or review for the test for tomorrow, okay? Just the most important ones. Let's go. When we talk about hospitals, we must consider that, well, first of all, this is well, I think the most important place we choose for studying, or maybe for living, we can say it becomes our second home because we have the chance to get in practice and feel that we are useful as doctors, right? As a definition, a hospital is an institution that is built, staffed, and equipped for the diagnosis of disease, for the treatment, for medical and surgical treatment, of course, for sick and injured people, and for their housing during this process. Of course, every patient has a different process, has a different time to stay into the hospital. We all know about it. We can make a deduction of this, but well, just a deduction. We can infer what's going to be, well, what's going to happen, right? When we say that it's our second home, it's because we spend too much time in there. A common phrase here in Bolivia says that a good doctor goes to the hospital when the sun is rising and comes back when the moon is up. So you can see we stay there lots of time. This is a general view of a hospital, a general view how it's organized. Of course, it's just an example because every hospital has its own organization, own divisions of services, of departments, and according the attendance, the assistance they bring, the assistance they offer, they organize by floors, by departments, by buildings. Well, it's according to the situation. And it's according to the objective of the hospital. We all know this. We have these charts showing us how they are organized and where we might go, where we are at the moment, for example, in the emergency department, and which services or departments are in level 1, for example, or in level 2, level 3, according to the situation, right? It's just for showing you that it's a very, very organized area. And of course, we have abbreviations in order to get it easier for us to check and see faster where we are going or getting into. Take this slide in count just for checking, because in Module 2 we are going to talk about it. Just taking count, general view, don't worry about this slide, just for information, okay, at this point. Let's go with some important meanings. For example, we have the outpatients. It's people who come to hospital to attend a clinic, to have a test or a treatment, and then return home the same day. They don't stay at the hospital. They are not admitted. They get the appointment with a specific doctor, or they receive the treatment, or they have a test, a lab test, or another kind of test. We don't know about it. It's not important at this point, but they go, receive the assistance, and then go back home, the outpatients. The inpatients are the people who stay in the hospital for one or more days in order to receive treatment. The way they are received are into the wards, of course. They can be coming to the hospital in different ways. They are admitted according to the situation. They can be put on a waiting list because they are not in an emergency situation. And according this list, this procedure, how the hospital is giving the assistance, well, they have to wait because of the treatment. For example, non-emergency surgery, right? They can wait 1, 2, 3, 4 weeks. It's according to the moment. Then in other countries, there's a possibility to get admitted by a telephone admission. That's people who are acutely ill. I mean, these people call to the hospital, ask for immediate assistance. The ambulance goes to their home, takes the patient to the hospital. The patient is evaluated at the emergency department, and according to the situation, they can get admitted. They have specific protocols to follow this information and decide if a telephone admission is available or not, of course. They have to give some details by phone, and according to the situation they are describing, doctors are expecting with all the resources that they need in order to give the correct attention. Another way are patients that are seen in the A&E department, emergency department, and the doctor on duty arrange the admission if it's necessary, okay? I mean, I am as an emergencist, I receive my patient, I take in count the lab tests, the evolution while staying at the emergency department, and that's all. If I consider it necessary for them to stay, well, they stay into it. If it's not possible, they are discharged by home. And of course, the discharge. When the treatment is completed, the patients go back to their GP's care. I mean, they have to stay in control, and it's the activity that the general practitioner develops when we talk about primary care in the previous presentation. That's a way of working in another kind of system or healthcare system in other countries. In Bolivia, when someone is discharged at home, they have to come back to the hospital for being evaluated once or twice according to the situation, and then everything is done. When we talk about health services, we consider that there are services that provide medical treatment and care. They can be public or particular group. There are some examples of particular and public ones, but of course, according to the country, we have their own institutions or systems. Health services, of course, are complex, are very different from one country to another, maybe with similar structure, but when we go to check by detail, everything is different, of course, and we have to be smart enough and take the most important data. In this slide, I'm showing you the healthcare system organizational structure from USA. just as an information for catching the idea. They have the healthcare system as a general idea and is divided in 3 points. Scientific healthcare subsystem. This is the one who is prepared. This subsystem is prepared for making research, for establishing protocols, for evaluating these protocols, and then sending information to the World Health Organization in order to improve the information for all the people around the world. These scientific healthcare systems have personal healthcare sector, just for doctors, nurses, professionals that are allied, but really allied to our medical profession, and the population care sector. The personal care sector is available just to take attendance to health services, health providers, I mean. The population healthcare service, healthcare sector is divided to the public health agencies, local, state, and federal. According to the situation, they can, well, a patient can be sent to the local, to the state, or the federal. It's according to the approach, the amount they are paying, the taxes, well, everything is very complicated at this point to get in detailed. Then there is the private health agencies, when you go and pay it month by month an amount of cash, and according to that, you get the services. And the voluntary health agencies. The voluntary ones, of course, are supported by donations by people who stand in these activities. They are with the less resources, but try to do as much as they can because they like to do it, right? Then the complementary alternative healthcare subsystem, the popular healthcare subsystem. This popular healthcare system is the one that, of course, is supported by the government, but to this place can go population that is without the health insurance, immigrants without all the documentation, without the green card, for example. They can go receive the necessary assistance, and according to that, they receive the treatment. Of course, they don't have too much resources for bringing the attention that sometimes is really needed, but they help a lot the population in order to save lives. For example, they attend labor and delivery, they attend accidents, but well, very, very critical situations just for saving life are getting established. Population has to pay a little amount of money. It's not the same as the rest of the subsystems, but well, at least it's still expensive. In this slide, I'm showing you the statistics, just as a previous way of talking. And statistics, when, well, that is supported by the World Health Organization. Details just for checking, information for taking in account, because information like this is the one we are going to check in Model 2. Statistics, percentages. Well, we're going to make comparisons between studies. It's very interesting. It's nice, Model 2. In Bolivia, of course, we have to consider our healthcare system. It's very simple in comparison to systems from other countries. It's very easy to understand because we have the national that is supported by the Ministry of Health, the departmental supported by the departmental government. The departmental government supports the departmental health service, the sedes, and the municipal health social councils, the consejos, we all know about it. The Ministry of Health is supporting, of course, the sedes too, according to some specific activities, not everything. And then we have the local and municipal one. They have the health networks, municipal government, and the SAFSI and MISALUD teams, new teams that are getting a general approach, we can say, to population, that is supposed to be vulnerable at this point, just as a general view. It looks like a mess, but it's not a mess. It's very easy to understand. And when you work inside of this, you can catch that it's, as an idea, is useful, but going to the reality, it's not as it is planned, we can say. We have the same statistics supported by the World Health Organization. Just check this for catching information, ways of expression. That's the objective of these slides. Okay, and let's go to the primary care, the important meanings. This is a slide that we are going to study, or we're going to check in the final test. Take this in count, okay? Well, we were talking about the general practitioner, the GPs, right? As a general view, we have the idea that's the doctor who develops activities for primary care just in some other countries. When we make a referral or we refer a patient, we support that the patient is sent to a specialist because the patient needs that attention, that care. Well, usually it's for secondary care. We have the home visits, to visit a patient at home as an appointment. They are made when patients are housebound, unable to leave their homes, or too ill. We go to the patient's house and we take it in control. We evaluate the situation and the patient according to the necessity we have, or the patient situation. But it's as an appointment. We have a schedule for going there. The home visits, this way of organization is very popular in UK, in the United Kingdom, and in some states in the United States. Also in Cuba, they have this way of organization. Here in Bolivia, the Ministry of Health is trying to establish this way of working, but until this point, it's not easy because of cultural reasons, I mean. We have the out-of-hours treatment, OOH. The OOH is a doctor that is into the consultant room, and he's just in that place for sending recipes, for sending treatment, okay? They provide by the local primary care trust and are organized in shifts, just GPs, because GPs are in primary care. They have a role, they have a schedule to stay in the consultant room, and population go there for picking up the medication and some indications for looking for details for catching up medication from the health insurance, and that's all. The one who organizes these kinds of shifts at the OH or into the hospital is a specific doctor. It's called the locum. The locum is covering the shifts if a GP or someone is absent, according to the hospital or the OOH primary care trust. This doctor has the role, is the responsible that these teams to the hospital and the primary care trust work properly. So let's understand this. This doctor, the locum, for example, if I have a shift at the OH at this consultant room, and because I got an accident and I cannot attend and nobody can go instead of me, this doctor is the one who has to go and make this consultant room works. There is no reason for not working at this place. The same at the hospital. If there is a situation, matter with what kind of situation, and the responsible is not possible to attend that shift, the locum has to go to the hospital and work on hospital. That's why this doctor has to be prepared in both areas, has to get experience for solving that kind of situations. Well, we were talking about the district nurses. They usually visit temporarily housebound patients, such as discharged hospital patients for not complicated procedures. For example, if a patient gets an appendicitis and the procedure is an appendectomy, everything is going perfect at the hospital, they discharge the patient at home, the district nurse has the capability to go to evaluate the patient, to take care of the surgical wound, to change the dresses, and then give information how the evolution of the patient is going on. If everything is okay, that's perfect. The patient just goes in once or twice to the surgeon or the general practitioner to check that the nurse is checking and making a great job. That's enough. That's why district nurses are very useful, and they get free the hospitals for not having it full of patients that at the moment are not necessarily. They are important, but it's not easy to establish a way of working like this. And I think in Latin America as a general view, because of cultural reasons. District nurses have the chance to organize their schedule, to prepare a route of working, a path every day, and then go and following that, well, check the patients, and that's all. Well, the change dressings, of course, I was telling you, is changing bandages from wounds, such as ulcer dressings. It's in some other countries like USA, UK, Cuba, it's developed by a district nurse, not specifically by a doctor. Doctors change dressings in the consultant room or at the hospital, not at home with the patient. Okay. We have the midwife. There's a trained staff who take care of antenatal patients, right? The midwives are nurses that take the control, make all the control of the pregnancy. But if there is something that is calling attention, a change, well, something that suddenly appears, the midwife has the capability to send the pregnant woman, the patient, to the gynecologist and obstetricist to get an evaluation. So as you can see, the hospitals are not filled with patients. It's easier to work in that way. That's why nurses are our right hand for working at the community. We have the health visitors, again, nurses that are trained. Nurses that are trained for going to the community. They go to visit the family, to carry out checkups on young children, on kids that are under 5. If they are healthy, that's perfect. They take the control, make the report, and everything is done in that way. The health visitors are supported in their action for avoiding possible infections while going to the consultant room with sick or ill children, or with infections that can get in contact, I mean. Healthy children, of course, is one indicator, one statistic indicator how a country is working on the population. That's why it's very important, this activity of health visitors. When I was at med school, I had a chance to go with my nurse to practice, to check how they work on this. And they go with a big school bag, carrying all the material they need. They have to go house by house in an appointment, following a route, following a schedule, and parents, of course, know about it. They know that there's a specific day when the nurse is going home to evaluate kids, and they have to stay there. According to this, they make the appointment for the vaccination. That's very important, not to lose the opportunity to use vaccines in children. That's why they're very, very important. It could be amazing if we can work in that way. That's preventive medicine. That's the way. Medical branches, so we can say, doctors and nurses go to the community. We don't only expect that the community comes to the doctor. We invert the idea. Okay, about medical education. We consider this as the process for becoming a doctor. The process for studying, for getting into the college, the medical school specifically. And we have this, the undergraduate education is focused on USA and UK, not for the rest of the countries, because it's different according to the place you are at the moment. The undergraduate education is usually supported by 5 years at the medical school, the section of a university responsible for medical education, of course. The undergraduate students receive all the theoretical information, little bit points, important points in practice, and according to the process they receive, they can work or they can be, well, they can receive as these titles: Bachelor of Medicine, Bachelor of Surgery. It's a five-year undergraduate medical degree course. You finish your 5 years in UK, for example, and you receive this first title. According to this, you can continue to the internship and then become a general practitioner. So most of your learning takes place in small groups. The main components are the core, 1 to 3 years, when you have a program of clinical and systematic topics that are presented through problem-based learning. It's very interesting when you start the career from the first year, checking the anatomical landmarks and make the relationship with the anatomical structure and the pathology. It's very easy to catch the idea and become, or understand is better to say, and understand the process of the pathologies. You have the study selected models, SSMS, allow you to choose from a menu of subjects in order to prepare for overseas selective. The overseas, the elective time when you can practice and check the information that is important at the moment. You have the vocational studies and clinical skills. And you have the chance to become prepared for the clinical skills that are required for contact with patients. This program, well, you can go to get in practice from the first year. You go in periods for practicing, for making processes, for using your hands, right? Of course, you have a supervisor that could be a nurse or a general practitioner that is, well, the locum, of course. And according to that, they support that you are prepared for continuing to the internship or through the career, for giving you some recommendations according to the specialty you are looking for. Then you have the clinical attachments for the years 4 and 5. When you have 4-week clinical attachments in medicine, internal medicine, surgery, psychological medicine, pediatrics, obstetrics, and gynecology, and of course, general practice, general practitioners. Why general practice? Because you go to the community, you act with the locum, you organize all the shifts, and you have the chance to stay with the doctor on duty in the consulting, the ambulatory consulting room, for knowing how the healthcare system is working at the moment, because all of these structures are changing according to the situation. With the COVID-19, all of the structures have been changing and being reorganized because of the necessity they had. Then, according how it is possible to improve or to change in protocols, they again are sent and reorganized for practicing better. Okay, this is just an information. This way of study, well, I had the chance to receive this way of practice. I had the chance to catch lots of different ways of working in Cuba. It's a very, very different way of receiving the medical career, the medical school. And well, while coming back to Bolivia, the contrast was the opposite situation. It's different. I tell you, my experience is amazing when you start from the first year going to practice with patients. Okay, practice is the basis in medicine. So we have the chance, let's do it. When we get the graduation or graduate, we must complete the rotating internship. We must do this process. We all know about it. The 6th year, the hardest one, because we are preparing the medical thought. According, you use these opportunities of working, of studying, of being in touch with patients. You can make this 6th year maybe easier or maybe worse. It's just your decision how you work on this. You receive the last most important topics, I think. You complete your rotating internship. And according to that, you have this daily activity, just a joke, don't worry. You know how to work on this, you know how it works when you wake up and you go through the day with all of these changes. When we finish the college, we receive our GP's title and we start, well, we feel that we are free from university, from medical school. We become the postgraduate doctors. Yes. We make our registration according to the country we are going to work. And it usually requires to go to the rural areas at the beginning for supporting. We are ready for working, right? Here in Bolivia, we have, well, it's into the internship. We have 3 months of service. But in other countries, it could be 1 year, 6 months. Well, it's different in each country according to the situation that is really needed. We know that going to rural areas, well, it's possible not to have all the resources. It usually happens. It's the same every place. But, well, that's the government's responsibility to give us that resources, right? We all know about it. We had the chance. The ones that are still at the university might have this opportunity. When you finish your rural service, you get your registration and everything, then you become a doctor. Now it's your responsibility to stay studying, to continue professional development. It's your responsibility to take courses, to continue reading, to follow the process by which health professionals keeps updated to meet the needs of patients according to the area you are focused. Tell you by experience, it's not possible to study all the branches. Of course, it's not. It's too much information, and every day we receive lots of research, lots of new protocols, changes in doses, in medication, in ways of acting. And, well, showing you my experience, these are the basis of my job for emergency departments. We have to be clear that there are associations that shows the most actual protocols in order for saving lives. I love emergency medicine, so I need the American Heart Association courses, the fundamental critical care support courses, the NAMD courses, the ITLS. So according to all of this, I can develop a better job because I have the information updated at the moment, following the needs of my group of patients, of the population I received. Right, it's not the same to work at the emergency room than work in a private consultant service or or into the hospital with admitted patients. It's not the same. It's very different. My objective as a doctor is to receive the critical patient, to start the critical care continuous, to support life, to stabilize the patient, to give the first diagnosis, and according to the situation, I decide which service is going to assist the patient until the recovery. When the patient gets admitted, this patient goes to the hands or goes to the care, to the assistants, to the specialists, into the service according to pathology. That's why I need lots of information, okay? It's the same if you decide to work in, I don't know, obstetrics, you need this specific course, for example, the obstetrics fundamental critical care support. It's amazing, it's nice. If you have the chance to develop these courses, do it. Very interesting. Well, this medical education is supporting the residency courses according UK in this case, with some similar details in USA. When we talk about a foundation, we must consider that it's an institution that is supporting that you are ready to start the residency course. And they, of course, have programs. The foundation program is a 2-year training program which forms or prepares the bridge between university and level study at medical school and the specialist or general practice training according to the area you are focused on. The foundation program, for example, in USA, it's possible to get there because when you are in the undergraduate years, the first 5 years, and you have the chance to go to the courses that I was showing in previous slides, you receive recommendations, letter of recommendations, right? According to those recommendations, you can approach, you can be selected to get into this group, and for 2 years you get into evaluations. It consists of a series of placements, each one lasting for 4 months, which allow a junior doctor known as a trainee. The trainee is the doctor that is being prepared in the foundation program. And they have to go in rotation, have to rotate in different specialties, for example, pediatric. We have the F1A, F2A, in order to organize which one is at the beginning and then. Each trainee has an educational supervisor. That's very interesting because supervisors ensures that senior doctors, the professors, deliver training in different ways, clinical and educational supervisor. They ensure that this supervisor has the opportunity to follow all the process these 2 years from these studies. And according to the progress, the trainee demonstrates the range of clinical competencies. According to that competencies, receive more recommendation letters. And according that, they decide if this doctor is getting into the residency course or not. Okay. You can repeat the foundation program, of course, following a different process for being admitted again. And according to that, you can get your specialty. In US, in UK, you have this chance. 2 years, it's the, as I was showing you at the beginning, these 2 years training are for showing that you are ready for becoming a resident, a useful resident. For example, you have this FYN and 2, and just for the 2nd year organization. It's based on an Australian foundation program, but it's very similar in different branches, in different countries. I mean, for example, for going to general surgery, when you finish this general surgery, you focused on a specific system. For being to general medicine, internal medicine, we can say, or for going to subspecialties like this, right? You go to all of the services that have surgical practice, we can say, all the places, all the specialties when you have internal medicine practices, and then you have the combination of them, and you have the general services, for example, accident and emergency rooms, anesthesia. GOSO general is the general practitioner. GOSO is because it's the island GOSO, okay? So don't worry about it. General practitioner, well, when you go to another country and you are recognized as a general practitioner, it's supposed that you have the capabilities for acting as a second surgeon. You have the knowledge, the basis of internal medicine in a general view, on a great support basis, and you can stand all of the service without any trouble because you have the training of doing this. That's why GPs has the opportunity to continue staying as a GP, but you know that you're going to stay at the primary care, covering shifts according to the necessities at the moment. Well, going into medical education, the responsibles about it, we have all of this just as an information. For example, the tutor is the academic that in some cases a postgraduate student who leads tutorials. Postgraduates go to the students to 1 to 5th year and they help them to understand, to catch information. Easy. The demonstrator is the one who's showing how, the one who demonstrates how to do an activity, how to do a procedure, a maneuver, right? The demonstrators are usually, again, postgraduate students that they are teaching in order to pay the college because, well, it's not easy. It's expensive, the medical career, right? The lecturer or the senior lecturer is the professor that has teaching and research responsibilities and contributes to teaching a particular discipline, for example, cardiology. Just cardiology, but this senior lecturer has to be able to develop research and then teach new doctors about it. Okay, the professor is the one, well, the academic that is teaching and making research in a particular discipline, for example, neurosurgery. And, well, they are an important figure in the discipline. They are the leading of the group, we can say. The college tutor, well, they're responsible to the college training program, of course. The college tutor organized this first tutor, demonstrator, lecturer, and professor according to the necessities and the amount of students. We have the clinical trainer, the clinical, well, the doctor that provides training during that periods of rotating services during the services, for example, in internal medicine, to develop as much maneuvers as they can, to develop the medical thoughts, that's way. And the educational supervisor is the one that is supervising, checking that the rest of the people of this chart are following the activities they have. The educational supervisor might be the jefe de enseñanza, as we can say in Spanish, right? According to that, we can go this. And about medical qualifications, of course, it's just general in order to consider that it's from UK, from United Kingdom. We have the Bachelor of Medical Sciences. And for example, we finish the medical career, the 6 years, the internship, we become a GP. We can make a short course, a 3 years course, just focusing on research. That's the Bachelor of Medical Sciences, the doctor that has the capability to make research and has the register to get into that groups of research, serious research, of course, in some other countries. the Bachelor of Medicine or Surgery, where we know we were talking about it at the beginning, is specifically for UK and in some states in USA. And when we got this, we become a doctor of medicine. The MD, very common, right? The MD is the one who has the 6 years and has the degree of becoming the Bachelor of Medical Sciences. Then the diploma of the Royal College of Obstetrics, for example, is the diploma of the Royal College of Surgeons, of Neurosurgeons, according to the specialty you got. And you become a member of these societies according to the procedures or the activities you have into your specialty. You have goals to follow on. According to the goals, to that topics, you can get admitted as a member of a society. When you become a member, you become a fellow, a professor of professors, right? This is the highest grade at the moment, but it's specifically for England, for example. And when you get the fellowship, you have the opportunity all around the world to work by free with this chance. But of course, for becoming a fellow, you have to follow all of this procedure. Medical school, to become a Bachelor of Medicine, then a Bachelor of Medical Sciences, then a Doctor of Medicine, then you become with the diploma of the college of your specialty, then you become a member of that specialty, and then you are a fellow. It's a little confusing, but that's the procedure. When we see the overseas of the doctor, well, it's just for UK, the information I got. And we take in count that, for example, me as a Latin American, as a Bolivian, I want to go to UK, I have to get valid my title, my college title, my college degree. And I had at the beginning to make a provisional registration that is supported by my qualifications from medical school in UK. I have to look for the same title, the same hours, the same studies. And with that, just I can work in UK. This is the first one, but it lets me, it gives me the chance for start working. I get into the clinical training with the foundation program, this 2 years program, and then I get the full registration. When I finish the 2 years, I get the full registration, and according to that, I can start the residency course. There are some colleagues that complete the foundation program just for receiving the registration, and they decide to go to another countries looking for the residency course. So they can receive the limited registration. They have the international medical graduates that have the chance to go for working to another places. For example, Italy, Germany, I don't know. Okay, the limited registration is just giving you the chance to go to some other places that are under control of the UK system, because the UK college is giving you the support that you are ready for working. That's why you have to be under control of this institution. When you finish the residency course, you become you get the specialist registration, and then you have the chance to get the certificate of completion of training. The complete training is done. So according to that, you can work on private or public services. That's the best. The PLAB by LIB is the Professional and Linguistic Assessment Board test. It's prepared in order to ensure that you have all the capabilities, all the practice that are safe, that support that you are a doctor that has all the capabilities for working in a UK hospital. capabilities while speaking English in a properly way, of course. The medical capabilities, medical knowledge, well, everything you need for working in the UK hospital. Just as an information, okay? And keep calm and carry on. As you can see, our career is not just a career. It's a way of living. We decide this lifestyle because we like it, I think. We are masochistas, yeah. We know that when we start the medical career, we have no properly life, we can say. No, we cannot decide by our own sometimes where to work, what to do, or something different. Well, that's the last presentation of Module 1. Very theoretical, I think, with lots of information that maybe shows you that it's different in other countries. It's not impossible to do it, but it's a long process. But the same process is followed by lots of people all around the world, and it's possible to make. Until this point, do you have any question?
No. Teacher.
Oh, okay, perfect. I just show you one slide. Let me open again the file to show you which slide you must review in order to take the vocabulary for tomorrow. Don't get mad about this. Okay. Let me share the screen and you have the chance to check this. There are two people who must fill the diary pool. Everybody can watch the diary pool?
Yes, teacher.
Yes, okay. I need two more. There are 11 from 13.
Could you send it again, please? I cannot see it.
Okay, Jorge, you cannot watch the screen, right? The pool.
No, it doesn't. The pool doesn't appear in my screen.
Okay, let me share it again. Let me see. Can you watch it now? Okay, perfect. One more. Well, for tomorrow, please check this. Let me see. Can you? No. Okay. Some important meanings. Slide number 6. And primary care important meanings. 12 and 13. That's all. Okay.
Okay, teacher.
Just these 3 slides for catching the idea what we are talking about, okay?
Okay, thank you, teacher.
Okay, so everybody fill the pool?
Yes, teacher.
Yes,
Okay,
teacher.
Yes, we
perfect.
did.
Is there any question, something you would like to punctualize before finishing? Because tomorrow, from this point until tomorrow, I'm not going to answer any question. You had the chance to do it. All the course yesterday and tonight. When we finish the Zoom call, I think everything is said. And well, I'm still taking scores and it's not possible to answer any doubt. You had the chance now. No questions? Okay. So as you prefer, we can finish now. And that's all. Have a great night. Keep on reading. And don't worry, you are prepared. I'm sure you are going to pass the test. You're going to prove without any trouble.
Let's hope for it. Thank you, teacher. See you tomorrow at 8.
See you
Thank you,
tomorrow at
teacher.
8 p.m. Don't
Thank you,
worry, I'm going to
teacher.
send a
Bye.
message to the WhatsApp group and you are going to get all the information very clear. See you at
Okay,
8 tomorrow night.
Okay, teacher. Bye. See you tomorrow.
Bye-bye. See you
Bye,
tomorrow.
teacher. Have a good night. Teacher.
Bye. Take care. Okay. Okay, everything is set. Everything is done. Let me close this. Yes, see you tomorrow in the final test.